Thank you very much, David. I really appreciate the opportunity to be here and talk to this audience. I am an allergist immunologist by training, so I always welcome the opportunity to address the hematologist. These are my disclosures. I acted as consultants for these drug companies. I have a patent on the LAD2 mast cell line, and I receive royalties from UpToDate. So why do allergists and immunologists see mastocytosis patients? It's a hematologic disorder. Because these mast cells are very active cells. They produce almost every cytokine that is known to man. They have histamine and other vasoactive mediators that are stored in their granules, and they also rapidly can synthesize a number of lipid mediators, and when they get angry or they get stimulated by allergens and other factors, stress, trauma, they release these cytokines and their granular contents, and that then causes a variety of symptoms in a number of tissues, including cardiovascular, skin, gastrointestinal tract. So, and we have mast cells in pretty much all of our tissues, so there's really not a single tissue that's spared of their effects. And so it is sometimes easy to confuse whether a certain symptom is caused by a mast cell activation versus a different type of a disorder. So when we look at the general group of mast cell disorders, the disorders of mast cell activation far outnumber the disorders of mast cell proliferation, and mastocytosis would be an example of a mast cell proliferation disorder in which the mast cells are produced abnormally from a hematopoietic progenitor carrying a KIT mutation in a clonal way. And then the mast cell activation disorders are where the mast cells are made normally, but they do get activated in response to other triggers, such as IgE-mediated allergic disorders and so on. So we certainly see more mast cell activation than the proliferation. But the patients we see with mastocytosis, which is a proliferative form of mast cell disease, also present with mast cell activation symptoms because they have high tissue burden of mast cells, and sometimes these mast cells get activated for reasons we don't completely understand. And we usually don't see allergies, IgE-mediated events in these patients very often, with the exception of bee sting allergy, which is a very interesting phenomenon, and we could probably dedicate a whole talk on that particular issue. But some patients with anaphylactic symptoms to bee stings that get hypotensive, it turns out about 8 to 10% of those patients end up having underlying mast cell disease. So it may be actually a more common diagnosis than we appreciate. And mast cells are obviously a hematopoietic neoplasm. We believe that they are derived directly from the multipotential hematopoietic stem cells, and they enter the blood as a precursor cell. We don't see mature mast cells in the peripheral blood. If we do see them, then that's usually not a good sign that the patient may be developing mast cell leukemia. And then they enter the tissue, and in the tissue they then turn into their mature phenotypes. Mastocytosis is a very variable disease. It can be seen in both children and adults, and it involves males and females in equal ratio. Estimated prevalence is about 1 to 10,000 to 20,000, so it is a rare disease. And the symptoms we see in these patients are mainly due to the mast cell-derived mediators like histamine. An example of that would be flushing, gastrointestinal cramping, hypotensive events. So about 70 to 80% of those patients would have those symptoms. And then the rest would present with hematologic disorders or disorders due to the excessive infiltration of mast cell into the tissue, interfering with the functioning of that tissue, acting like a true neoplastic or malignant neoplastic disorder. For example, liver infiltration with liver dysfunction, ascites, or extensive gastrointestinal infiltration with malabsorption and weight loss, or very extensive bone marrow infiltration leading to cytopenias could be example of these symptoms. I already talked about this. About 10 to 15% of these patients may present with anaphylaxis and no other symptoms. So they have these recurrent events of flushing, low blood pressure, they pass out, and then they go to an allergist. They have all the allergy testing done, but nothing comes up. And then somebody thinks about checking a tryptase level, which is a surrogate marker of mast cells. And if the tryptase level is increased, then that patient is referred to a hematologist for a bone marrow biopsy to establish the diagnosis. About 70% of the patients present with a skin condition called urticaria pigmentosa. I will show a couple of pictures of these. So if you suspect mastocytosis, it is important that you do a good physical examination and look at the skin in these patients. And interestingly, about 5% present with pathologic fractures, and these patients may not necessarily have the other symptoms of the disease, and the first presentation may be a pathologic fracture in a young person, otherwise who have no reason to have a pathologic fracture. So this is a skin lesion in an infant, urticaria pigmentosa. As you see here, this is really not urticaria as we know it. It's not hives. These are fixed lesions. They are there all the time, but they may turn into a hive if you scratch those areas. And this is an adult patient with urticaria pigmentosa or maculopapular cutaneous mastocytosis. And these lesions tend to spare the sun-exposed areas. So if you look at the patient, you know, the face and the hands are spared, so you really need to look at the hidden areas. Again, these are fixed lesions. Now, if the patient is a child and if the lesions started within the first year of life, those children have very good prognosis, and about 90% of them grow out of these skin lesions, and they don't have systemic disease, meaning they don't have internal organ or bone marrow involvement. So we usually leave them alone. We don't get too aggressive in terms of treatments with those patients. We just manage their symptoms with antihistamines. As opposed to the adult patients who present with this skin lesion or the other symptoms that I mentioned, those patients almost always have systemic disease, meaning they always have a bone marrow involvement. So our rule is when we suspect or diagnose a patient with mastocytosis in adults, we always refer them for the bone marrow biopsy. And this is a persistent disease. It doesn't go away, and there is no cure. Despite we have made some advances in the last 10 years, there is still no curative therapy for the disease. So why do we look at the bone marrow? And that is because the WHO criteria require that we do this examination, and we have the major criterion here, which is the collection of these mast cells that are stained positively for tryptase, or you can also stain them for c-KIT or CD117. And then there are the minor criteria, these spindle-shaped mast cells as opposed to a round mast cell, and the CD25 expression on the surface of the mast cell, the elevated tryptase level that I mentioned, and the presence of a KIT mutation in codon H16, which I will talk in a few minutes. This is a very heterogeneous disease with different prognosis. This is the updated 2016 update on WHO classification. There are a few minor differences with the previous version of this classification. The first one, we broadly divide the disease into cutaneous, which is generally seen in children, versus systemic mastocytosis in adults. And then in systemic mastocytosis, there are 5 different subgroups. Indolent systemic mastocytosis is the group where the patients present with a benign disease. They have the mast cell collections, but they don't die of mastocytosis or a hematologic disorder. And then there are the more advanced variants, such as mastocytosis associated with a hematologic neoplasm, and those are mainly myeloid in nature, myelodysplasias, myeloproliferative syndromes, occasionally a non-Hodgkin lymphoma or a plasmacytic disorder. And the aggressive mastocytosis that presents with organ failure and a mast cell leukemia, which is very rare, with greater than 10% mast cells in circulation, or greater than 20% in aspirate smears, and the smear is the keyword here, not the biopsy. And then there is this transitional category called smoldering systemic mastocytosis, which denotes patients with high degree indolent mastocytosis with high mast cell burden, and those patients may have a high likelihood of progressing into one of these other categories. As opposed to indolent patients, the rate of progression is around 3 to 5%, and it may be up to 10 to 20% in the smoldering systemic mastocytosis. And why do we do this classification? Because it tells us about the prognosis. This is from the Mayo Clinic group, from Dr. Teferi's group, that compares the life expectancy of patients with mastocytosis in red versus the life expectancy of general US population. And as you see here, the life expectancy appears to be reduced. But then when you break these down into their respective categories, the patients with indolent, the benign form of mastocytosis, which fortunately comprise about 70% of all the patients, have similar life expectancy as opposed to those patients with aggressive systemic mastocytosis and those associated with hematologic disorders. And there is a line here that denotes the mast cell leukemia, which has an average survival of less than 6 months, which has a very poor prognosis. The disease is associated with KIT mutations. It's a clonal hematopoietic progenitor cell disease, and in more than 90% of the patients, there is one single mutation here that involves codon 816, D816V point mutation. This can also be seen in about 30% of the children, and the rest of the children may have other mutations in the extracellular part of the KIT molecule, and KIT is a tyrosine kinase receptor kinase molecule, and it binds to stem cell factor and dimerizes and then initiates protein phosphorylation through this domain here. And when this mutation occurs, it obviates the need for the ligand binding, and it's a constitutively active kinase. Now, there are other mutations in mastocytosis, and that explains why we see such a big clinical heterogeneity. Just like in other myeloproliferative neoplasms, we see TET2, SRSF2, ASXL1, RUNX1 mutations, especially in combination with the KIT mutation. This is a study from my colleagues in Mannheim, Dr. Reiter, and he found that these the light blue are the patients with benign indolent mastocytosis, and the others are more advanced forms of the disease. And as you can see here, these mutations are clustered with the advanced forms of the disease and is a poor prognostic factor. This mutation, KIT mutation, is also important because it determines partially the treatment we choose for these patients. Currently, imatinib is the only FDA-approved kinase inhibitor for mastocytosis, but it doesn't work in the great majority of the patients because this mutation confers resistance to imatinib. It's a somatic mutation, so if you check it in the peripheral blood, you may get a negative result because we are not supposed to, again, have mast cells in the peripheral blood. And the commercially available tests only detect 0.01 to 2% if the allele burden is, it has to be at least that much. The treatment, there are 3 major categories. We treat all patients with symptomatic management with anti-mast cell mediator treatment. And if they have an associated hematologic disorder, that disorder needs to be treated according to the guidelines of that particular disorder. Mast cell cytoreduction is indicated for patients with more advanced forms of the disease, such as aggressive systemic mastocytosis and mast cell leukemia. So this, in terms of symptomatic treatment, we use H1 antihistamine, second generation, like fexofenadine or cetirizine, combined with H2 antihistamines, such as ranitidine, antileukotrienes, such as montelukast, NSAIDs, aspirin can be used in some patients, blocking prostaglandin. Oral cromolyn sodium can be helpful in patients with more gastrointestinal problems than diarrhea. I always prescribe a self-injectable epinephrine to these patients because they are at high risk for anaphylactic events, as I mentioned, for bee stings or sometimes idiopathically. Steroids are very good for patients who experience malabsorption and gastrointestinal involvement, and also it's good for liver disease. And omalizumab, which is an anti-IgE monoclonal antibody, is also useful in reducing the anaphylactic type episodes in these patients. And here are two patients. It's currently FDA approved for asthma and chronic urticaria, not for mastocytosis. But if the patient has asthma or concurrent urticaria, we could use that. And there are two patients who have been experiencing recurrent anaphylaxis. And when omalizumab was started for their asthma, those anaphylactic episodes also stopped. And we don't know why it works in mastocytosis because it's not an IgE-mediated disease, but it does. Now, let's talk about the cytoreductive treatment of mast cell disease. So these are the options: alpha interferon, cladribine, polychemotherapy, like as if you are treating AML, stem cell transplantation, kinase inhibitors, and clinical trials. So alpha interferon has fallen out of favor recently. It was the first cytoreductive therapy to be employed because it has a slow time to response and it's associated with a lot of side effects. A lot of patients can't tolerate it. But it may be particularly useful in patients who experience bone disease and bone fractures. And usually combined with prednisone, and this is the usual dose. Pegylated form has also been used. And the overall response rate is about 50%, with the major response is about 20%. And cladribine became the first line of treatment because it acts rapidly. This is the dose here. The side effects are cytopenia and immunosuppression. And the overall response rate is better than alpha interferon, up to 70%. And this is a study from the French group comparing overall survival versus relapse-free survival with cladribine. And this is a difficult graph to interpret because they also included indolent mastocytosis, which we would not advocate cladribine because of the side effects. But it looks like it has especially some activity in a mastocytosis associated with a hematologic disorder. I mentioned Gleevec or imatinib is the only currently FDA-approved kinase inhibitor, but I only had 2 patients so far in the past 15 years who were really good candidates for Gleevec because this KIT mutation creates a resistance in the molecule. So this is that one of those 2 patients. We discovered that she had a transmembrane mutation, not the codon H16, so it didn't affect the Gleevec binding site. And we treated this patient with Gleevec, and you see that the tryptase level, which is a surrogate disease marker, improved very nicely. Now, this patient periodically stops this treatment, and then the tryptase level goes up. So we know that it's not a curative treatment, but it is palliative. Now, why is this approved then if it's not a very good treatment? And that's mainly because of a confusion with another disorder, chronic eosinophilic leukemia. At that time was called hypereosinophilic myeloproliferative hypereosinophilic syndrome. These patients also have elevated tryptase levels here, and they have increased mast cell burden. Some of them may look spindle-shaped, and they respond very well to Gleevec. And and they can be sometimes confused as having mastocytosis, but these patients obviously have a different molecular lesion, a PDGF receptor alpha fusion with FIP1L1, and that's the target of Gleevec, not the kit, and they present with a completely different clinical picture, so they don't have mastocytosis. But because these patients were initially confused as having mastocytosis, and they were published in high-profile journals, that was one of the bases for the approval for Gleevec by FDA. Now, midostaurin is a multi-kinase inhibitor. It's currently in clinical trials, and there is a large phase 2 trial that was published in New England Journal of Medicine last year. And it does produce good responses, especially in patients with mast cell leukemia and then aggressive systemic mastocytosis. The 50% survival has not been reached as of the publication of the study. So it has not been approved. It's currently under accelerated review by FDA, but I think when it gets approved, it will change the guidelines for this treatment, and it will replace cladribine as a first-line treatment. And it also decreases the symptoms. The only symptoms that doesn't decrease is nausea and vomiting. It's because the side effect. It even also improves the hair loss, so that might be something that I might consider for myself at some point in the future, or even now. Okay. Stem cell transplantation has been used with some success, especially in patients with associated hematologic disorders and aggressive systemic mastocytosis and mast cell leukemia. We don't know which patients are the optimal candidates for this drug, but we do know that the myeloablative regimen works better than the reduced intensity conditioning regimen. And finally, my last slide. There are some investigational treatments, a couple of kinase specific D816V inhibitors, Blue 285 and DCC 2816, early stage clinical trials. Siglec-8 is a surface marker that sends negative signals to the mast cell surface, also expressed on eosinophils, and there's a new monoclonal antibody that is being tried that mediates antibody-dependent cytotoxicity. And then CD30, another pathologic surface marker on mastocytosis. So these are small-scale clinical trials. IL-3 receptor and ibrutinib have also been tried. And then finally, combination treatments. And it is likely that no one single agent will give us the improvement that we have, and we may end up combining cladribine with one of the kinase inhibitors or use them as a conditioning regimen for stem cell transplantation in the future. Thank you very much for your attention.